I wanted to talk to you with less really data, but more experience and sort of how to train your eyes when you are examining patients so that you will know what to expect if that person needs to have surgery. I have no disclosures, but all the podcasts from the Otolaryngologic clinics of North America are free, and you can get them wherever you get your podcasts, or you can get them at oto.theclinics.com. They're really good. I just recorded a couple that will be out in the next few weeks. One on salivary tumors and the other, but really outstanding conversations with these world experts who are the guest editors of each issue. So on the right, on this side is a drawing of the right ear, and this side is a drawing, is an actual picture of the left ear. And when you are looking through the ear canal, you see that the short process of the malleus points anteriorly, The manubrium has an oblique lie and ends at the umbo, same thing here. In the posteral superior quadrant of the drum, which is here and here, you should be able to see a shadow of the incus, a shadow of the stapes. You might even be able to see the stapedius tendon. Sometimes you can see the chordotympany nerve as it crosses here, and the chordotympany nerve always crosses lateral to the long process of the incus and medial to the long process of the malleus. It is a really useful landmark in chronic ear surgery and should not be sectioned or taken away lightly, particularly if you are fighting some amount of granulation tissue or heaped up mucosa, because it really gives you a very nice barrier between safe lateral to it and somewhat dangerous, which would be the stapes, the facial nerve medial to it. As you look at the drum, you will see that antero-inferiorly, you see this cone of light. It is always described, I have seen it in healthy ears and I have seen it in unhealthy ears, but people still look for it. The larger portion of the drum is called the pars tensa, and the smaller portion, which is bounded by the notch of Rivinus here, is called the pars flaccida. So attic retractions, attic perforations, attic cholesteatomas happen up here. So when you're examining the patient, you shouldn't be looking straight. You have to look straight and you have to look up so that you can see everything. So when, endoscopic ear surgery has given us an amazing appreciation of the anatomy of the ear, but this is again a left ear. So here's the short process of the malleus, here's the manubrium, here's the umbo. This is the neck of the malleus, which then goes to the head. This is the incus. This is the incutostapedial joint. So that is actually not between the long process, but between the lenticular process of the incus and the head of the stapes. You can see the stapedius tendon coming out of the pyramidal eminence here. You can see the promontory here and the round window niche, and the round window membrane is up. So you often will have like an adhesion that's sort of flat across this round window niche. That can actually be removed if you want to take a look at the round window membrane, which is up here. The internal auditory canal will be anterior and medial to the bony lie of the eustachian tube. This is the tensor tympani muscle here, which turns at the cochleariform process and gives off the tensor tympani tendon to the neck of the malleus. This is the horizontal facial nerve, and that cochleariform process is a really nice landmark. It's cochleariform, which means spoon-shaped, even though it's right next to the cochlea. Don't blame me, I'm not an old anatomist. But this is where, from our perspective as surgeons, the facial nerve goes anteriorly and then turns at the cochleariform process into the genicular ganglion. So in real life, obviously, it comes from the genicular ganglion to its horizontal lie. But as we're looking at it, it's coming like this. And then you can see some hypotympanic air cells here, and you can actually, with an endoscope, look back here, which is the sinus tympani, and it's sort of a hidden space for many microsurgical approaches. So that's a very nice way to look, very anterior, very posterior, superior, posterior with an endoscope. So when you see somebody who has chronic otitis media, as a trainee, I would recommend that you describe it to your attending or your professor using these terms. So this is a patient with chronic otitis media with a perforation, or this is a patient with COM without a perforation. This is an active case, means there's infection, inflammation, drainage, or it's inactive, it's sort of quiescent and really going to be a pleasure to operate on. Active COM is a bear to operate on. There's too much bleeding, there's too much inflammation, there's fear all the time that you're hurting something because you're just waylaid by the inflammatory response. I want you to tell me if you think that there is cholesteatoma in this ear. So you can have chronic otitis media without cholesteatoma. That's one type of disease. You can have chronic otitis media with cholesteatoma, and that takes us down a different pathway of how we operate and how we follow up and how we counsel before we even get there. Are there any complications? Is the patient presenting with a mixed hearing loss as opposed to just a conductive hearing loss? Is the patient presenting with dizziness? Is there some evidence of a lateral canal fistula because every time air goes in or they drive with their car window down, they get dizzy, or if you insufflate, they get dizzy or vertiginous? Is there facial palsy? Was there facial palsy? Are there other things that might lead you to think that there are some complications of the COM going on? What is the degree of hearing loss? And I think that one of the ways to improve your own performance is to look at the patient, don't look at the audiogram, tell yourself what you're seeing and what you anticipate the hearing loss is, and then look at the audiogram and see if you were right. And if you were right, you're training yourself very well. If you were wrong, either you need more training, or there's a problem with the audiogram, or there is something hidden that you cannot see yet, and your pincers should rise. You should say, oh, let me make sure there's nothing else going on in this ear.
So when you say predict the degree of hearing loss, do you mean use a tuning fork to try and...
We use tuning forks, but even by exam, you should be able to tell me, frankly, this anterosuperior perforation that's about 10 or 12% will have no hearing loss, whereas the same perforation over the round window membrane might have a 30 or 40 dB conductive hearing loss. So yes, I want you to use tuning forks, but I also want you to get a sense of what you expect that audiogram to look like, so that you and the audiologist are better parts of the hearing healthcare team for the patient. Was that helpful?
Super, thank you.
Okay. Look for eustachian tube function. So that means one ear is bad. Is the other ear bad, or is the other ear fine? Is there retraction on the other side? Is it a child? Is it somebody who's sniffing all the time like this? Are there some allergic shiners under their eyes? Is it a person, adult or child, with just a lot of nasal and nasopharyngeal secretions? Have they needed several sets of tubes? So I did a really nice paper when I was a fellow with John House, and we looked at 830 or 850 pediatric tympanoplasties. And the real predictive indicator for failure was actually the number of sets of grommets or myoanatomy tube insertions that the child needed. The status of the other ear was very important, but the number of grommets. So if it was 3 or more, they had a pretty high likelihood of failure versus 2 or less. And then we looked at, of course, the nasal secretions, the age, and we found that 9 and above, when the eustachian tube is really gone from its horizontal lie to more of its vertical and across lie is the safest time. But in a child without other issues, you can actually do a tympanoplasty younger if the eustachian tube nasopharynx status looks pretty reasonable. Status of the opposite ear, just to give you a sense of the milieu of the patient, and then how snotty are these children or adults. So if you say, okay, Dr. Chandrasekhar, I'm presenting for you a patient with chronic otitis media without perforation. So you can have somebody with either meringosclerosis or tympanosclerosis, and meringosclerosis is the calcification that is limited to the head of the tympanic membrane, and tympanosclerosis is calcification that affects the ossicles, for the simplest definition. And so even a very thick tympanic membrane can, just by its thickness, give you some conductive hearing loss. If there's ossicular fixation from the tympanosclerosis, it's usually found in the epitympanum between the lateral wall of the epitympanum and the head of the malleus, or encasing both the head of the malleus and the body of the incus. You will know from histology that the lateral surface of the tympanic membrane is epithelium. The medial surface of the tympanic membrane is mucosa, and then that central layer between the two is a fibrous layer that has actually two layers, a radial layer and a circular layer of fibers. The calcification that we see in meringosclerosis and tympanosclerosis actually starts in that medial fibrotic layer. So if you have good hands and patience, and you're operating on somebody with a perforation who also happens to have some tympanosclerosis or meringosclerosis, as you're elevating your flap, you can actually do a very nice dissection where you peel the epithelial part of the drum off of the calcified chip that's in the fibrous layer, and then you can remove the chip, and then when you put the drum down, it's actually still intact with this chip of tympanosclerosis gone. It's a nice exercise. It's a really nice way to learn how to use your hands in microsurgery very effectively. Other chronic otitis media without perforation, you can see what's called a shrink-wrapped tympanic membrane. So this, if you can see the superior and inferior, you can see there's a retraction here. There's a little bit of airspace anteriorly, but there's a nice full retraction of the posterior half of the pars tensa. The incus and stapes are in relief. They're still under the drum, but they're in relief. The chorda tympani is clearly seen here. The promontory is clearly seen. Round window niche is clearly seen. And then you do have some airspace here. And this is, ears like this are why we can't say that all problems stem from the eustachian tube, because obviously the eustachian tube is aerating the front of this person's ear. So this is a right ear, and again the head of the short process of the malleus is pointing anteriorly. The manubrium gets oblique away towards the central umbo. The posterior external auditory canal at the tympanic ring is more oblique. The anterior external auditory canal has an acute angle. This is very important if you are doing onlay or overlay tympanoplasty. So if you have a total perforation or you remove all of this and you're reconstructing the whole thing, one of the complications can be blunting at this anterior angle, which results in a 20 to 30 dB conductive hearing loss, because you have not stopped your repair here, but you've come up onto the canal wall, and because it's an acute angle, that soft tissue that you put here becomes blunted like this. So we see that in congenital oral atresia cases where we're building a brand new tympanic membrane. We see that in onlay technique, and there's some really nice modifications of the onlay that can prevent blunting as much as possible. Here on the left ear, so again, acute, obtuse, here's short process, here's the umbo. you see actually there's some tympanosclerosis that's sort of holding that tympanic membrane up in the proper orientation anteriorly, but then the rest of it is down. The whole promontory is here, the chorda tympani nerve is here, the incus stapes are here. If I get this person to the operating room, I will always ask the anesthesiologist if they can give some nitrous oxide for just a couple of minutes and do some positive pressure, some Valsalva maneuver to see if this is being done under general anesthesia, to see if I can elevate this really retracted drum off of all of these structures. If I can actually strengthen this with either a thick fascia or a cartilage tympanoplasty and see if I can help that. Sometimes with a temporizing tube placed here. The old days of having to remove every bit of laryngosclerosis or tympanosclerosis in order to repair the drum are really no longer valid or present. So what about a chronic otitis media, no perforation, but ossicular erosion? So obviously we can see this. And here again, it's a left ear. There's some anterior laryngosclerosis or tympanosclerosis. It looks like it has a thickness to it. This is the membranous annulus here. And you can actually see some normal looking tympanic membrane between the anterior edge of this tympanosclerosis and the membranous annulus. So if I'm operating on this, I'd be quite tempted to do that dissection between the epithelial layer and the calcified chip to see if I could remove that and then go ahead and reconstruct the entire surface, because you really do have a very nice anterior margin left, even if you perforate in the process of doing that. You have some retraction here. This is the neck of the malleus. This is the head of the malleus. Here's the short process. Here's the umbo. You have some tympanosclerotic changes here, or laryngosclerosis. And then you see chorda tympani. So here you have long process of malleus. You see long process of incus, but then it disappears, and you see the head of the stapes. So this is the most common ossicular erosion secondary to chronic otitis media, with or without cholesteatoma, is erosion of the long process of the incus. And the reason that that is the most common is because that part of the incus has the poorest blood supply. So you have sort of this nice radial blood supply coming down the malleus. You have some feeders coming from the drum. You have a nice blood supply to the body of the incus. You have a nice blood supply to the stapes. But right here at the very bottom, where there's been some pressure on that long process, it just doesn't have the stick-to-itiveness and it can erode. And often you'll see a partial erosion, but as long as it's intact, you can leave that alone when you are repairing it. Here on the right drum, so short process of malleus, umbo, anterior tympanomeatal angle, posterior tympanomeatal angle. Not only is the incus gone, but actually the head of the stapes is gone, and you sort of have that drum sitting on the shoulders. Now, people who look like this and like this may look scary, but if their hearing loss is less than 20 decibel conductive hearing loss, you're probably not going to do much better repairing them. And as long as you don't think that this is too deep of a retraction that you can't clear it in the office, you can actually watch these people over time and they actually do okay. Here, you can see there's no further erosion. If this had been caught earlier when the drum was sticking to the incus, that would have been a good time to intervene to prevent this. But this has already happened, and it's probably just going to sit there for the rest of this person's life. So then the last little bit of chronic otitis media without perforation is retraction. So we talked about retractions. If it's a shallow retraction and you can actually see all the way around like this, and you can clean any debris that's there. Here you have some tympanosclerosis. Here you have a little, it's just just an unpleasant ear. But if it's hearing okay and the person's doing okay and they're quite comfortable with you cleaning under the microscope, you know, every 6 months or every year, you're okay. If their hearing is, again, within about 20 dB conductive hearing loss, you're probably fine. In this instance, it's also a left ear, but this is a little bit deeper, and I'm not sure if I can see the posterior edge of this or the superior part of this epitympanic retraction very well. And again, this is a really nice area for microscopy in the clinic, as well as the use of endoscopes in the clinic. So if you have an endoscope set that you can have for clinic examination, this is very, very helpful for these kind of cases. Here, it's a ugly looking ear, but the retraction is quite amenable to staying clean. So I'm not really worried about this. Here, somebody's put some powder in the ear, I think, to dry it up. But again, the thing I want to know, if you're saying to me, I think this person needs surgery or doesn't need surgery, is that retraction shallow? Is it deep? Do you think it's active? Do you think that the erosion of the ossicles is going to continue? Should we repair this so that they don't run into a problem where instead of just doing a type 1 tympanoplasty, now we have to do a ossiculoplasty as well? And then, of course, yes.
So 2 things about the last slide. One is, so the summary that I'm taking is that as long as you can see the retraction pocket and the hearing loss is not progressing, then actually we can just observe.
Yes. So what you want to see is the base of the retraction.
Yeah.
That's really the important thing. So here I can see the base of this without a problem. But here, I would really look up here. That superior epitympanum is a nice little hidden location. And then just behind, just posterior to this, I want to make sure that that's not a pocket going deeper and posteriorly towards Otitis ad antrum.
Right.
So if I can see all of that, and I see that it's clean, I see that there's no evidence of cholesteatoma sort of like spewing out from there, we can keep an eye on this here.
Don't you want to intervene before it progresses, before you get that hearing loss, before
Right.
you get that erosion?
Correct. So if you're okay, and again, you know, this is very different when you're in private practice and you know that the patient is coming back to see you. But if you're in a clinic setting, where even if you try to educate the patient, it's just maybe, quote unquote, falling on deaf ears. They just may not be able to understand. You don't want this person to be clean today and then show up 5 years later with an epidural abscess because they were never followed up, right? So it really depends on the setting in which you're seeing the patient. In the United States, a great deal depends on whether they're going to keep their health insurance. Yeah. We have, you know, all of our dirty laundry has been aired during this COVID pandemic, so we apologize for being just terrible people over here. But you know, if they can't come back for care because it costs quite a bit to come in to see the doctor.
Yeah.
So you know, you really have to think about. There's always a risk reward of, do we intervene now, make it a cleaner ear, you know, send them along their way. You know, and if this person says, you know, the thing I hate is I just can't jump into the sea with my kids or my friends, or I can't jump into a swimming pool, or, you know, we have a house in Greece or something like this. You know, you can make this a safe ear. Yeah. Where you have halted the progression with a nice little cartilage graft here, and you can almost even leave this alone because this is self-cleaning. It's this one that I'm afraid of here.
Yeah. Thank you.
So you can see combination disease, right? So we've talked about this a little bit. And here you can see in this left ear, you have an acute anterior angle, an obtuse posterior tympanomeatal angle. You will often find this sort of like Hansel and Gretel like trail of cerumen coming from the retraction pocket. And it's nice because it kind of helps you clean up that pocket. But here you see a retraction, here you see a retraction, here you see some meringosclerosis. It's a little thinner looking than that big chip that I showed you in that other ear. And so here you have tympanosclerosis with retraction and erosion of the incus. So the thing that's missing, look for the thing that should be here. So the thing that should be here is the long process of the incus. So here on this right ear, we have a beautiful, like if you block this, look how pretty that is, right? It's got this beautiful sheen to the drum. You can see the shadow of the eustachian tube, shadow of the tensor tympani semicanal. You can see this cone of light that every pediatrician is pointing out all the time. I don't know what it is. But then you look at this posterior half of the drum and you look up into the pars flaccida, retraction with some little bit, you might say this is scalloping and you might not. Really, scalloping is a word you use for a CT image that's consistent with cholesteatoma. But then look at this. So this is the posterior wall of the tympanic ring. This should be here. Can you guys see my pointer?
Yes, we can. Very clear.
So
yeah.
that is supposed to be there. And it's actually supposed to be here. And then there's a little notch and then it's here, right? So the education part is to know what it should look like, what the relationships of all the structures are, and starting with that normal that we started with. Now see what's going on in this ear. So now we're missing a significant portion of the scutum, right? So this is like what I might remove to do a stapes surgery. I might remove, well, I wouldn't remove this much bone, but the guys in Béziers would definitely remove, they remove a lot of bone for stapes surgery. So this is something like you'd remove to either do a stapes surgery, get access to the attic, or do sort of an inside out mastectomy. This is so cool. This is iter chordae posterior. So as you will know, the word iter in Latin means tunnel. So this is the posterior tunnel of the chorda tympani nerve, iter chordae posterior. It has come off a facial nerve in the mastoid. It's come up and it's entered the middle ear space. And now it's going lateral to the incus and medial to the malleus. And it's going to go out iter chordae anterior, which is on the anterolateral superior side of the bony eustachian tube. Very cool. So this is iter. This is the pyramidal process. This is the stapedius tendon. This is a nice intact head of the stapes, or it's possibly the end of the lenticular process of the incus. Sometimes you get in here and you actually see that that joint is still there, and this little round bone is actually what's left of the lenticular process. The chorda is lateral to the incus, and you can see quite a bit of the body of the incus and some of the short process of the incus, which obviously you're not supposed to see through the ear canal. But then you can see that it's missing here. So the long process of the incus has been eroded away. So there's really either a membranous connection between the incus and stapes or no connection. You can see the promontory here, and some light is reflecting off of the intact drum that's a little bit down towards the promontory, towards the round window niche, which is right here. And this is the facial nerve. So this is horizontal facial nerve. And like I said, the horizontal facial nerve is going to come like this, and then it's going to turn back here to the geniculate right at the same spot where the cochleariform process gives off the tensor tympani tendon to the neck of the malleus. So you're seeing too many structures here, and this person should have quite a bit of hearing loss. Did I get it right? I got it right. You never know with me.
Prof, what sort of hearing loss would you expect with this picture?
So this person, when there is an intact drum and a ossicular chain discontinuity, you actually get a maximal conductive hearing loss. However, this intact drum is on the stapes. So it's almost like a laryngostapediopexy. So instead of a 50 or 60 dB conductive loss, I would expect in this case, probably around a 40 dB. I think you're going to gain something with the laryngostapediopexy.
Which is otherwise known as a type 3, correct?
Oh yeah, but I hate those.
Yes.
I hate them because I hate things that don't make sense to me that then I have to memorize. So I just hate that. I'm sorry.
No, I agree. I agree.
But yes, I think so. So if you tell me it's the drum is down onto the foot plate, that would make me much happier than if you tell me it's a type 4.
It makes more sense. It's more translatable. Yeah.
Yeah. See, you made me so angry. I have to take off my my jacket. So here is all the things we just talked about. So if you're going back and looking at this, please stop the pause here and make sure you can identify these structures, and then make this list and make sure you hit all the list, and then put the label thing there. Okay? So now we've gone from chronic otitis media without perforation to chronic otitis media with perforation. So I want to know the size of the perforation, I want to know the location of the perforation, and I want to know whether the ear is dry or moist, which is a pleasant operation, or purulent, which is a horrendous operation that makes you sad that you went into the operating theater that day. So you can see on this right ear, we're seeing a large kidney bean shaped perforation. The superior portion of the drum is intact. The superior portion of pars flaccida, the pars flaccida is intact. You can actually see the notch really well there. So this would be, you know, maybe I would call this a 75% or 80% perforation. Through the perforation, I am seeing the dark cells, the darkness that's going into eustachian tube orifice, so that's the protympanum. I'm seeing hypotympanic air cells. I'm seeing the promontory. I'm seeing Jacobson's nerve, which is a branch of glossopharyngeal and runs superior to inferior over the promontory. This is the site of origin for glomus tympanicum tumors. As I'm looking at the promontory, I'm looking at the round window niche. The round window membrane is that. It's not that, it's that. Very important when you're doing cochlear implants that you don't put cochlear implants into hypotympanic air cells. You're seeing the malleus, you're seeing the chorda, right here. You're seeing the incus, you're seeing the stapes, you're seeing the stapedius tendon, you're seeing the posterior cruce of the stapes. This sort of dark thing, which is described as robin's egg blue, is the footplate of the stapes. And here you see the horizontal facial nerve.
Prof, can I just ask, can you quickly just go over how you would approximate the percentage of the eardrum? Do you divide it into quarters?
Yes, so it's a great question. So you essentially forget about this for a second, because if it's an epitympanic retraction or perforation, I want you to tell me that. So we leave the epitympanum alone for the moment. But if it's a pars tensa situation, this is a circle. So you kind of just divide it into quarters. And you can say that this is a kidney bean shaped inferior perforation. And based on sort of the surface area, it's about 75–80% perforation, because that's, you know, 20 to 25% is left, probably 20% is left. It's dry and it's central, and it's central because I can see, I can see annulus all around it, right? So the marginal means the lack of membranous annulus. And the reason we care about whether there's a membranous annulus or not is because if it is marginal, so if there's no annulus here, the epithelium from the skin can easily enter the middle ear space and cause cholesteatoma here, wherever it's happening. But we actually have a preserved but small margin everywhere. When I'm repairing this, I could either do an onlay graft or I can do an underlay graft and make a small collar button incision here, make a little tunnel between that incision, which is about 2 millimeters lateral to that anterior annulus, make a little tunnel under the skin over the bone into the middle ear space here, and put a small finger of my graft under that tunnel so it comes out into the ear canal here. That actually secures it anteriorly, and then the rest of it falls into place really well. But that's how I would describe this. So you really want to look at the circle that is the tympanic membrane. The tympanic membrane is about 10 millimeters in diameter. So you can describe it in terms of size. So you would say this is an 8 millimeter or 9 millimeter perforation, 8 millimeter probably. You can describe it as percentage, and you should say where it is in terms of which quadrant. And this is dry and safe, it's ready for surgery. You can be fooled with a monomer, which is actually a dimer, because it only has the epithelial layer and the mucosal layer and no fibrous layer. So you can see these monomers here versus a perforation like this. And if you're not sure, if you do pneumatic otoscopy, this drum should move, this drum should not move. If you are not sure still, you can actually puff a little bit of powder in there, like boric acid powder or CSF powder, which is chloromycetin, sulfanilamide, and fungizone. It's a sort of a very old-fashioned, very effective way of treating chronic otorrhea. But puff some powder, the whole drum will have the powder on it here, whereas the perforation will be outlined by the powder here. I actually did that when I was a resident, and I found that that was a very nice way to teach myself, to teach my eyes how to see. So here's chronic otitis media with perforation. This is a left ear, acute obtuse here. So I'm gonna tell you, I find this to be marginal, so I don't see annulus here. It is postero-inferior, about 25%. It is infected and inflamed. It's red and angry. There's some anger inside the middle ear. There's definitely some drainage going on in the ear canal. And it is exposing the round window niche. So it is removing that baffle between oval window movement and round window movement that allows us to maintain really good hearing. So here, these are the situation, and because it's marginal, there's a high likelihood of acquired cholesteatoma going posteriorly inside the middle ear here. And for this person, I think they're going to have about a 30 dB conductive hearing loss. Whereas if this same perforation with all of the bad things was here, you might have no hearing loss at all, or maybe 10 dB hearing loss. It's the posterior portion of the drum, where inferiorly you have round window that's exposed, or superiorly you can have incus stapes that's exposed, where you'll get the most hearing loss if it's a relatively small perforation.
Prof, what's the percentage perforation of this?
I would call this about a 25%.
Yeah, you can see that clearly if you divide into quarters, actually.
Right. Yeah. And if you want your attending to operate, don't say 20%, say 25, right? Because it's really there. So if you see multiple painless dry perforations, as you see here, there's a whole bunch of other stuff going on here, some tympanoid sclerosis. Think about tuberculosis. So tuberculous otitis media is actually a thing. We're still seeing it. We're not over with tuberculosis. But just it's something to think about, where they just kind of appear with hearing loss and perforations and no other story. So now we're going to look at two different types of perforations, and we're going to talk about all of the things that are written down in yellow there. So this is the right ear, this is the left ear. This is an antero-inferior perforation. This is a posterior perforation. I would say this is close to 50%. This is closer to 20–25%. A nice annulus here. This is okay. It's dry. It looks funny in this picture, but there's also a nice annulus here. You see really nothing of interest here. You're seeing some protympanic cells and some hypotympanic cells, but really nothing of great interest. Here, you're seeing lots of great interest, right? You're seeing the promontory, seeing the round window niche, you're seeing the incus and stapes, you're seeing stapedius tendon, and then there's a little bit of tympanochlorosis here. So this is obviously a more chronically infected or chronically damaged ear than this one. And if you look at this one, we talked about all of this. This is a safe ear, and I really don't expect a hearing loss, like I would not expect a hearing loss if you put a grommet in this area, right? So it's very similar because for me, ideally, the grommets are placed anterosuperiorly, but they can be placed anywhere here. And this really should not yield a conductive hearing loss if you're using a grommet. Grommets are smaller than this, but not by a whole lot. This one has quite a large perforation. So in my, I guess before I thought it was 3/4. Yeah, this is not perforated. So I don't know why I said that. I would say this is about a 50% perforation. It's dry, there's some tympanochlorosis, all the things that we talked about. This is not such a great ear because any water that gets in, a person puts in a Q-tip, they're in a big mess. It's not as unsafe as having a marginal perforation, but I expect a 40 dB conductive hearing loss with this, and this is something that would be quite amenable to repair. Well, both are quite amenable to repair. The reason to repair this is to be done with this patient so that they can go about their life and swim and so on and so forth. And the reason to repair this is to restore hearing and make this a really safe ear. So we're talking about different types of perforations. You can have a dry perforation like this, dry perforation like this. You can have a moist perforation like this, and you really want to dry this up before you try to do anything surgically because your outcomes are going to be better the drier and healthier the ear is. And then this drum has an anterior perforation with just mucopus just pouring out of it from the eustachian tube. So this is posterior, this is anterior, that's the eustachian tube orifice. And this person is also sitting there gunk full of mucopus in their nose and their nasopharynx. So you really want to treat their underlying issues before you even consider repairing this. If you repair this with just this Niagara Falls of mucopus coming at you, that repair is going to fall apart. So cholesteatoma is keratoma or skin growing where it doesn't belong. It can be congenital or primary, and it can be secondary or acquired. And this is a surgical disease. We don't have cholesteatoma dissolving drops. We don't have cholesteatoma dissolving pills. And this is truly a surgical disease. With the advent of endoscopic ear surgery, the gravity or the destructiveness that we have to do as surgeons is getting less and less, which is very, very nice. So we can actually remove a lot of these cholesteatomas without doing some secondary things like taking the canal wall down, making a big meatus, etc. But respect cholesteatoma because this will recur if it's not fully removed. So this is a nice little drawing of an epitympanic cholesteatoma that's sort of filling the epitympanum and approaching the tegmen or roof of this is tegmen tympani, this is tegmen mastoidea. This is a right ear, large perforation, and then the middle ear is sort of filled with this cholesteatoma here. I have to tell you, when I see it like this, I'm happier because this is sort of just hanging out in space. And, you know, I would get a CT scan on this, but I think when we remove this, this is going to be very amenable to full removal and then reconstruction. Whereas when I see this is also a right ear, and this is an epitympanic cholesteatoma, and it looks really adherent, you know, into the epitympanic walls, and that has a higher propensity for me leaving a bit there or recurrence. This is a scarier looking disease for me, or a more concerning disease for me than this. This kind of looks like it will be a lot of fun when we go into the operating room to remove it.
With regards to,
Yes.
so sorry.
Mhm. Yes.
With regards to the previous photo, ideally, when would you like to get this case into theatre? What's the time frame?
So as soon as possible. I would like to get a CT scan. So when I did my residency at NYU, we kind of didn't really, we got CT scans on everybody. When I did my fellowship at the House Ear Institute, they were like, we know what the ear looks like. Why do we need to get a CT scan? Which is 100% true. So you're not getting a CT scan as a roadmap, but you are getting a CT scan because if you see tegment erosion, if you see what looks like early lateral canal erosion, if you see what looks like ossicular erosion, you can actually counsel the patient better and you can be better prepared for the surgery. So I'd like to get the CT scan. This, you know, as ugly as this looks, it actually looks rather beautiful to me. This can wait a little bit. This can't really wait that long. Like I would try to calm this down. I'd get some drops, maybe some antibiotics, get that redness down. Like, you know, there's very little, there's a small slip between the cup and the lip when you look up in the epitympanum in terms of extension. So it is not an emergency unless they're having some intracranial or some complication. But you'd like to get these in within the next month or two.
Sure.
So why do we operate on cholesteatoma? Because this is what intracranial abscesses look like. This is what acute mastoiditis looks like. This is what dural venous thrombosis looks like. So we want to make a safe, dry ear. We'd like the person to hear again, and we want to prevent all of these complications: erosion of the ossicle, worsening of the hearing loss, sensory neural hearing loss that can occur, facial nerve weakness or twitching, mastoiditis, and of course these intracranial complications. So the total incidence of intracranial complications from otitis media is 8%, but 30% of otitis media complications are in fact intracranial complications, and up to a quarter of intracranial complications from otitis media result in death. When it's from chronic otitis media, the patient's course can be very, very indolent, and then suddenly they present with this epidural abscess or intradural abscess or with a sinus thrombosis. So this is showing you, I'm sorry, this MRI is just showing you this chronic otitis media in here, this dural enhancement that goes all the way medially, all along the surface of the petrous. So what are the complications that you can see? Meningitis, cerebral abscess, lateral sinus thrombosis, extradural abscess, which is in B. You can see otitic hydrocephalus, and you can see encephalitis. Last couple of what do you see? So here we have two right ears. It's very hard to tell that they're even ears because they're so ugly. But this is the anterior acute angle. This is the posterior obtuse angle. You know, obviously the patient's in front of you, so you know it's their right ear or left ear. But if you want to look kind of smart, you could do this. Here you see a huge perforation with cholesteatoma. This is hypotympanic air cells. This is round window niche. That up there is facial nerve, and this here is chorda tympani. You see a little bit of drum that's left here, and this bit of cholesteatoma seems to be wrapped around the manubrium and the umbo of the malleus. This is a dry ear, but it is an ugly ear with cholesteatoma. This is a wet, infected, you see actually granulation tissue here in the anterior epitympanum. You're seeing pus sort of filling the ear canal, a big bulge in the posterior tympanic membrane. So here you see this total or subtotal perforation, superior cholesteatoma. This is the eustachian tube orifice here. You see the, I thought that this, so when I looked at this in the, at home, I thought that there's a tensor tympani semicanal here. I'm not sure about that. You definitely see facial nerve, round window, and hypotympanic air cells. On this one, you're seeing this superior granulation tissue or polyp should tell you that there's cholesteatoma. There's some otitis externa, and the anterior drum looks okay. So it looks like there's cholesteatoma sort of in this location, deep to an intact drum. And here we have two dry ears. Here they're also both right ears. Here you have a posterior retraction. The incus is eroded. The head of the stapes is visible. I don't really see cholesteatoma here. It's ugly here, and I would really look in here either with a microscope or an endoscope to try to see how deep this goes. On this one, the pars flaccida is actually pretty nice. There's some meringosclerosis. This is a monomer, but you see a large epitympanic cholesteatoma with erosion of the lateral epitympanic wall. So here, what you should look for is you want to see the congenital cholesteatomas when they look like this and not when they look like this. So you want to look really, it's really anterior to the neck of the malleus, but you can sometimes see anterior to the umbilical of the malleus. It's just a nice little pearl just anterior to the malleus. It can be missed for a long time. Sometimes people make a mistake and just make an incision in here for their grommet. If you can find it like this, you can shell it out and it's really fun. If they come like this and they haven't really had a history of otitis media, you suspect that this is a congenital cholesteatoma gone awry. So it's really very nice. You can take out this little pearl. There's an imaging of a little pearl of this anterior to the neck of the malleus cholesteatoma, and this is what it looks like. It's very nice if you don't have to cut the anterior portion of the drum, and you can just shell this out from transcanal, elevate your tympanomeatal flap, get your endoscopic ear instruments in there, and just kind of shell it out that way if possible. It's quite a fun operation to do. So just to remind you about otoendoscopes, because I promised Dr. Iyer I would. So this is a right ear, and you can see this beautiful facial nerve here. You can see chorda tympani lateral to the incus. It's going medial to the malleus before it exits the iter chordae anterior. You're seeing the pyramidal process or pyramidal eminence here. You're seeing the stapedius tendon here, the head of the stapes here, lenticular process, incudostapedial joint, head of stapes. You're seeing the posterior crus of the stapes here, promontory here. This is Jacobson's nerve here. This is the round window niche here, hypotympanic air cells here. Round window membrane is going to be here. Oval windows here, round windows here. They are at 90 degrees to each other, always. It is a beautiful, the middle ear is the most beautiful place on earth. And that is always the truth of where they are located. So this is your posterior mesotympanum. In the left ear here, you're looking really anteriorly. So here is the malleus. Here's the drum reflected anteriorly. This is the tensor tympani semicanal. This is cochleariform process. So this is the spoon-shaped process, cochleariform, that's giving the tensor tympani tendon to the neck of the malleus. If you can look at this, this is right under here is where that congenital cholesteatoma would be. And you can really shell this out beautifully with an endoscope under direct vision. You can also do it with a microscope, depending on how well you can airplane the patient away from you and yourself away from the patient. This is the anterior epitympanum, or the supratubal recess, really nice place for hidden disease sometimes. This is the incus, this is the lenticular process, this is the head of the stapes, and again, the posterior crus. Here's promontory, and here's round window. This horizontal structure here, that's going medial to the incus, above the stapes, is the facial nerve. And again, it's going to turn right here. This is the geniculate ganglion up here. Just when you get a CT scan for cholesteatoma, you should know why you're getting it. So you want to look to see, is the tegmen intact? Is the horizontal or lateral semicircular canal intact? This kind of looks like there's something going on at the semicircular canal, but if you look at it on 2 images or a series of images, you'll see that it's okay. This is clearly a horizontal canal fistula. You can look at a normal side here, and this is really nice. You see facial nerve here. I'm sorry, you see tensor tympani muscle here, cochleariform process there, and then this is facial nerve here, sort of that snake eyes of the horizontal, beginning of the horizontal section, end of the geniculate ganglion here. Nice, beautiful cochlea here, malleus here, sharp sputum here. That's really what you want to see. Here, you see this epitympanic disease. The sputum is eroded. There may be some scalloping that you notice on the bone here. And this in the mastoid is probably inspissated secretions as opposed to cholesteatoma. The CAT scan can't tell you the difference other than the bone around it. The tegmen looks very nice. The facial nerve looks protected by bone, which is very important. You can get an MRI to try to distinguish for yourself that this is cholesteatoma and this is not cholesteatoma. I don't actually think there's a reason for that other than if you're writing a paper. Here you can see that same sort of epitympanic lateral to the ossicles, and here you see the scalloping. This thing is called scalloping, where the bone kind of looks like that, is scalloping. Here you see beautiful stapes foot plate, pyramidal process, cochlea, vestibule. And then as you come down from here, you see a little bit further disease, just as we start to see the external auditory canal. So you can kind of get a very nice sense of where that cholesteatoma is located, whether you can approach it transcanal, post-auricular, microscopically, endoscopically, and often how much you have to counsel the patient that this may be a 2-stage procedure, depending on the status of the ossicles and the inflammation at the conclusion of the case. So just to tell you, MRIs are really nice when you're looking to see if that blob is in fact just scar tissue or chronic otitis media versus cholesteatoma. And what you want to look for is a non-echoplanar diffusion-weighted MRI scan, no gadolinium, no reduction in sensitivity, and cholesteatoma will be hypointense on T1 and hyperintense on T2, and it will be restricted on diffusion-weighted images. So this is really important. It's something to sit down with the neuroradiologist and just go over it over and over and over again so that you understand what you're looking at. So here, just some representative, you don't know if this is cholesteatoma or chronic otitis media or this, but here you see some enhancements here. And then on diffusion weighted images, you're seeing that it is cholesteatoma. And then with contrast, you see that it's inflamed on the sides, but it has there's no contrast inside it. So it's not a glomus or a neuroma. These are 2 images on CT that look basically the same, right? You can say, oh, they're just kind of the same patient, except the sphenoid looks a little bit different in these people, right? If you take a look at the MRI, this one is significantly different than this one. So you're really looking at trying to distinguish whether this blob in a maybe normal looking drum is cholesteatoma versus this blob, which is just cholesterol granuloma. You can have false findings, so you can't only rely on your radiologist. So they may call it a granuloma, but I have to tell you, there's more scalloping here than I would have expected from just a cholesterol granuloma. So I think you have to have a healthy dose of skepticism when you're looking at your own images. And then you're just going to take a look and say, am I going to see an intact tegmen? Am I going to have a canal fistula, a external auditory canal fistula, what are the ossicles going to look like, and then of course, what is the facial nerve going to look like? There's a cholesteatoma sac, and they're kind of trying to remove the cholesteatoma around it, having done a mastoidectomy here. This is very inflamed looking. There's some cholesteatoma here, but lots of granulation in the mastoid. And then how do you manage the canal wall? So I tend not to take down the canal wall almost at all. I think I've done it in fewer than a handful of patients. I think with good microsurgical techniques, with good endoscopic techniques, with good imaging as your second look, I think you can manage these patients really well. And then you don't make them, crazy about their ear, because they need to live a full life not thinking about you. I want to thank you guys so much for allowing me to take up your Monday evening like this. If there's any questions, I'm happy to take them.